afternoon. This is Dr. John Bennett televising from Nepal. We're out in the Garden of Nepal. I'm here with Dr. Mohamed Reda Elaziz, a neurosurgeon from Egypt, and he's going to talk on post-traumatic CSF leakage. And we're also joined with a guest from Croatia, who is, by the way, is the next speaker. Hey, Slaven.
Hello, hello everyone. My name is Slaven. I'm from Croatia. I'm a senior medical student, and I will be really happy to give my speech today and to listen to Dr. Reda's speech. To be here.
Sometimes I refer to Slaven as the wonder kid of neurosurgery. Anyways, I'm just gonna. We don't have any microphones here, so I'm gonna give the headset to Dr. Elaziz, and he's going to start his presentation. So I'm turning it over.
Thank you, Dr. John. Hello, everybody. I am Dr. Mohamed Reda Elaziz, lecturer of neurosurgery at Elaziz University from Egypt. Today, I will talk about post-traumatic CSF leakage. This is my country, my beloved country, Egypt, where the pyramids and the river Nile are present, where 7,000 years ago, the first human civilization was born on our land. This is my university, my beloved university, Elaziz University, where I work. First of all, I would like to thank my professors, Dr. Hazem Saad Suleiman, Professor Dr. Sami Hassanin, and Professor Dr. Tariq Abdelbaki, and great thanks to my brother, Muhammad Yahya, for assisting me in performing this talk. CSF leak is one of the most scared complications in skull-base surgery because it carries a high risk of infection, especially meningitis, separates, and brain abscess, with the attendant high mortality rate. Let's start with anatomy of the anterior cranial fossa. The anterior cranial fossa is formed from 3 bones: orbital plate of the frontal bone on both sides laterally. Really, it forms the orbital roof. In the midline, we'll find the cribriform plate of the sphenoid. Posteriorly, we'll find the lesser wing of the sphenoid bone ending as anteroclinoid process and the body of the sphenoid. Pathophysiology. CSF leakage, in order to occur, there must be disruption in the tissue barrier separating the cranial cavity above from the sinonasal tract below. This barrier, in fact, is the dura of the anterior cranial fossa and the bone. Regarding the dura of the anterior cranial fossa, it is very thin, fragile, and highly adherent to the underlying bone, so it is easily to be torn with fracture involving the anterior cranial fossa. Regarding the bony part or the bone barrier of the anterior cranial fossa, it is formed by the thin orbital roof and the thin and perforated cribriform plate of the ethmoid. So this is the commonest site where CSF leakages occur, and it's the commonest site to be fractured during anterior cranial fossa base fracture. Classification of CSF rhinorrhea. CSF rhinorrhea can be classified into 2 big groups: traumatic and non-traumatic causes. Because this group is considered as a traumatic one, non-traumatic causes of CSF rhinorrhea will not be discussed. Regarding the traumatic causes of CSF rhinorrhea, it may result from either iatrogenic or surgical trauma or accidental trauma. The first one, the iatrogenic or surgical trauma, which results in CSF leak, may result from ENT procedures or neurosurgery procedures, because the skull base is merely a part separating the cranial cavity from above from the sinusal tract from below. So any operation, especially the endoscopic one, involving sinusal tract from below or operations involving the cranial cavity from above can result in CSF leakage. Regarding surgical or iatrogenic CSF leakage, the ENT procedures, especially the endoscopic sinus surgery. Endoscopic sinus surgery can now be considered one of the most common procedures in daily ENT practice. The most common site for iatrogenic injury of the anterior scalp base during endoscopic sinus surgery is the lateral lamella of the cribriform plate. Because the lateral lamella of the cribriform plate is the thinnest part of the scalp base, so it can be easily injured. Number two, there is a marked variation in the depth and the slope of the lateral lamella of the cribriform plate. Here is defined three types of cribriform plate configuration with increasing depth. Type 1, the depth is 1 to 3 millimeter. Type 2, from 3 to 7 millimeter. Type 3, from 7 to 17 millimeters. And there is an additional fourth type, in which the cribriform plate differs from one side to the other one in the same patient. We must know that with increasing the depth of the cribriform plate increases the liability of iatrogenic injury of the cribriform plate with the resultant CSF leakage. Hence, the importance of good preoperative studying of the coronal images of CT to identify which type of cribriform plate is present, or the degree of depth and sloping of the lateral lamella of the cribriform plate. You must study the preoperative images very well in order to avoid any intraoperative surprise. In fact, surgeon's experience plays a role or a major role in CSF-related endoscopic sinus surgery. It is a less common complication with experienced surgeons. Number two, the nature of the operation, whether this is a first operation or a recurrent one. Regarding the neurosurgical procedures which result in CSF leakage, number one, the classic transfenoidal approach to the cell latersca is associated with CSF leakage if the arachnoid was injured and forgotten to be repaired, whether it was surgical cell or form or fat, a bed of fat. Number two, if there is inadequate repair. In this image, with the era of the expanded endonasal approaches to the scalp base, early attempts were associated with a high rate of CSF leakage, reaching about 45 up to 50% in some series. Well, with the introduction of the novel technique of Haddad flap, the nasoseptal pedicle vascularized flap, the rate of CSF leakage has markedly fallen down to only 5% of cases. After the introduction of the Haddad nasoseptal flap, Haddad nasoseptal flap can cover any defect in the anterior scalp base or in scalp base from the posterior of the frontal sinus down to the clivus. After the introduction of Haddad flap, many types of endoscopic scalp base reconstruction was developed, like multi-layered techniques, introducing fasciolata graft from underlay or onlay, introducing dermograft, introducing fibrin glue. Other middle turbinate flap was designed. Also, extranasal pedicle flap like peritoneal flap was introduced. All these types of flaps, whether regional or extra-regional flaps, all are aiming to prevent or reduce the incidence of post-operative CSF leakage. Other neurosurgical procedures which are associated with CSF leak. Number one, if accidental injury to the frontal air sinus, the accidental injury to the frontal air sinus occurred during bifrontal craniotomy and not repaired, forgotten by surgeon. Number two, inadequate obliteration of the frontal recess during cranioization of the frontal air sinus. Number three, following resection of a pneumatized anterior clinoid process during aneurysmal surgery or scalp base surgery. And finally, failure of healing of the already repaired defect because the patient may be diabetic or a long-term use of steroids or immunosuppressive drugs or debilitated. Finally, accidental CSF leak or non-surgical or non-iatrogenic causes of CSF leak. The commonest cause of accidental CSF leak is head trauma. CSF leak occurs in about 2 up to 3% of patients of head injury. Other causes include direct violence or industrial injuries. The incidence of CSF leak after fractures of the anterior cranial fossa is about 5 to 6 times more common than that resulting from fracture base, middle cranial fossa, or posterior fossa, being the thinnest part of the skull base is the cribriform plate, and being it is the easily one to be ruptured and injured. The most common site of fracture in the anterior cranial fossa is the ethmoid cribriform plate, being the thinnest one. And the cribriform plate, merely it is not a plate, it is perforated by foramina of the olfactory phyla, which will form the olfactory nerve. The second most common site is the posterior table of the frontal sinus. The third one being the orbital roof, and the last one is the sphenoid sinus. Usually, it is not an isolated fracture, but it is multiple fractures, one involving the orbital roof, and one involving the posterior wall of the frontal sinus, and one involving the cribriform plate. Clinical picture. The patient may present in the acute phase with epistaxis, periorbital ecchymosis, or the classic Dracon eyes, ecchymosis, and if the eyes can be opened and examined, there may be loss of vision due to injury of the optic nerve. There may be limited extraocular motility due to injury of third or fourth or sixth nerves. As we see in the first image, this is a sign of fracture base, which is retro or post-auricular hematoma or ecchymosis. The patient also may present with delayed manner or may present in delayed manner or in the clinical chronic phase, where he can present with meningitis, complicating unnoticed or neglected CSF leakage, brain abscess. It can also present by intermittent nasal discharge or merely a salty taste in the nasopharyngeal area, in his mouth, because of chloride content. Okay. How can we diagnose a case of CSF leak? In brief, we can diagnose a case of CSF leak, number one, from the history, number two, from the examination. When we notice a clear water discharge from one nostril or the other one, it comes in a continuous manner or in intermittent manner. It increases when the patient leans forward or doing Valsalva maneuver. It's okay. We can also diagnose CSF leakage by lab, searching for beta-2 transferrin or beta trace protein. Imaging plays a major role in the diagnosis of CSF leakage, especially CT. High resolution CT with axial, coronal, sagittal, and 3D reconstruction can accurately determine the site of the defect and detects the delicate anatomy of the floor of the anterior cranial fossa. CT sternography can be used if there is an active leakage of CSF during the time or at the time of intracecal administration of the contrast, or when CSF leakage can be reproduced by Valsalva maneuver. MRI and MRI with contrast or MRI sternography may also be used. If there is an occult CSF leakage and the site cannot be determined, we may proceed to intracecal injection of fluorescein. But let's concentrate in the post-traumatic cases. CT is the golden rule. What about the management of CSF leakage? Lines of management of CSF leakage may be conservative line of management. If failed, we'll proceed to CSF diversion, and if failed, we will proceed to surgical treatment. Conservative treatment consists of bed rest, head elevation of the patient, and the use of the antibiotics to prevent infection like meningitis, antibrain abscess, but the use of antibiotics is a matter of debate. We must bear in mind that about 68% of cases of CSF leakage, post-traumatic CSF leakage, will spontaneously stop during the first 48 hours after trauma, and up to 85% of cases of CSF leakage will stop during the first week of trauma. So conservative treatment is very, very important with certain precautions like no wire insertion, like avoid coughing or stooping forward, like avoid constipation, laxative may be given and tough suppressants may be given. If conservative treatment failed, we should try for 7 up to 10 days, and some series may prolong this period. CSF diversion may be tried. There are two types of CSF diversion. One method is a very simple method, which is a lumbar drain, which may be used after transvenous surgery when there is resistant CSF leakage. Okay. The other one is the AVD. The AVD, it is considered to be more invasive than lumbar drainage. It is also an easy procedure. It is used if there is an indication for ICP monitoring. In this case, AVD plays a dual or a double role. One for ICP monitoring, and the other one is for drainage of CSF and drainage of CSF. That's okay. Regarding surgical treatment, there are two types for management of post-traumatic CSF leakage, either from below the endoscopic or either from above the transcranial approach. I will present a case for transcranial procedure for repair of post-traumatic CSF leak. This is a 22-male patient presenting to our department 1 month after the trauma by intermittent nasal discharge from both nostrils and associated with osmotic disfigurement, as we see. Bicoronal skin incision was performed starting from the tragus, less than 1 centimeter, in order to preserve the superficial femoral artery, which is the main blood supply to the flap, and the facial nerve branches. Okay, then passing behind the hairline about 2 centimeters, then crossing the midline about 2 centimeters behind the mid-pubic line on the opposite side. The section was done in layers, as you see. Okay. Elevation of the pericranium was done, and here we see the site of the fracture. Okay. Removal of the bone flap was done via sinking per hole on the posterior aspect of superior structural sinus and sinking per hole on the anterior aspect of superior structural sinus at the nasion, and 2 per holes, one in each side at the McCarthy line, or the McCarthy point. Okay, after elevation of the bone flap, as we see, the superior structural sinus is intact and both frontal air sinuses appear. So, cranioization of the frontal air sinus was done, meaning removal of the posterior wall of the frontal air sinus, cautery of the mucosa of the frontal air sinus, then pieces of muscle from temporal muscle were taken and put into the sinus. Extradural dissection were made at first to remove some fragments which were present, then interdural section was done with posterior retraction of both frontal lobes under the carotenoid plates. As we see, repair of the frontal sinus was done. The pericranium was sutured and closing and separating the cranioized frontal sinus from the remaining cranial cavity. After that, the pericranium, which is the gold standard for repair of anterior skull base, is thrown inwards and sutured to the dura overlying the laser wing of sphenoid. Then the pericranial, then the bone flap or notomy flap was repositioned again and fixed with many plates. Thank you. Thank you, John.
Okay.
Thank you.
Okay, very good. Thank you. Yeah, Slaven.
Yes.
Yeah, Mohamed came here from Egypt along with his associate, and he's spending a couple of weeks with Yuha. Well, do you have any questions or comments to Mohamed about the presentation?
Of course, I would like to thank Dr. Mohamed for presenting here, because this is a novel platform, and it is really meaningful for us around the world to hear experts speaking in this field. I think this presentation was, it was really concise. It was, you can see that it was presented by a world-class presenter, and I'm really happy that it's a nice review of one of the very important topics in neurosurgery, and that is CSF leak. I, as a student, do not have so many resources to study this phenomenon and to more about it, and I think this is a really nice sujet of this very important complication in surgeries, which I heard lots about.
It is a very important and life-threatening complication if not treated well.
Yes, exactly. And I heard that usually there is this watertight closure. It's very hard to stop the CSF leak once it appears, and that it must be done with both dura and fat tissue from the patient. That this is the best. ANS, for example, advise this. Yes.
You
Please
speak about the classic craniotomy flap, but if you are addressing the case like that I showed it, this is a traumatic patient, and you must identify where is the site of leakage, and you cannot repair the basal dura. Repair of the supratentorial dura during craniotomy flap, it is easy, but to repair a torn, traumatized anterior base dura is very difficult. So we resort to either graft or a flap. As I show you, this flap, this pericranial flap, is the best method for repair of the anterior fossa. But we can use also the fascia lata. The fascia lata gives the same strength and good site or good substitute for healing and fusion of the defects of the anterior cranial fossa.
Thank you very much. I think I really do not have any more questions. I only would like to again comment that this is really remarkable, and I am glad that Professor Juha is still pulling people from various sides of the world, and I think that this relocation he had is very nice for some people to come and see him, because it is really I hope you will enjoy in Nepal, and I hope that this will really fulfill wish to learn from a master and to work with him.
Thanks a lot. Nice to see you. Thanks a lot.
For this presentation, I would really like to hear more of your presentations if you have some time in the future, and thank you again.
It's okay. I will prepare a series of lectures with my professors at the university, and it will be at a regular basis, and I will inform dear John.
Great, thank you very much. I will come and listen to you, and it is really a pleasure to learn from such a master.
Thanks a lot.
Thank you.
Thanks a lot.
Dr. John, I would like to ask you, can we give some time maybe in between the lectures, because Samer, who is in Japan right now, would like to come, and I'm not sure that he asked me when will it start. Can you please, does Dr. John hear this?
Yeah.
Dr. John Bennett.
Yeah,
he can. Yeah, so I'm just.
That's okay.
He cannot hear this. Yeah.
Okay, we got to increase the budget to get more headphones, Slaven. What were you saying?
Okay. Yeah, I was just saying that Samer was from Iraq. He texted me and he said that he would like to come for the hangout, but he cannot make it still. So I think, can we make a break between the two hangouts of about half an hour?
Yeah, sure. Sure. We can do that. We can do that. I'd like to thank Mohamed. This is an impromptu request to do the O'Hara. There's another one. Well, at least you can introduce. I can introduce you to Mohamed. Hello, Hera.
Hello.
Hi, Hera. We're just wrapping up here, but Slav is going to be back in like a half hour for another presentation. Okay.
Okay.
Okay. So we'll see. Let me introduce you to Mohamed.
Hello.
Hi, Hira.
Hello. How are you?
Fine, thank you.
Okay, thanks, Mohamed. This was, like I said, impromptu, and we did it at the last minute. So we'd like to thank him, and we hope we can get the Egyptian community of neurosurgeons to participate in these hangouts, including the Neurosurgical Students Society. So we'll wait till Slavin's presentation in about a half hour. Thank you very much.